of interest is more toward the critical care and nutrition. So I'm going to talk today about a very interesting topic, which is nutrition in critically ill COVID-19 patients.
Sorry, doctor, if you can talk a little bit closer to your mic, it would be much appreciated for everybody.
Thank you. So initially, I would like to thank Nestle for sponsoring this presentation without any obligation from marketing point of view. When you talk about COVID-19, it's a very challenging topic for everybody because actually we don't know much what to do. We don't have a strong evidence here. Many questions will be raised, and the answers are few from all over the world. So we are still building experience. COVID-19, you know, the outbreak is terrible. It involves around 193 countries all over the world. So it is really a very bad pandemic, and remind us by Spanish flu 1918. Not only that, but the healthcare workers also infected with the virus is terrible. If you go to Wuhan, initial town with COVID-19, around 50 or 63% of the healthcare workers get infected. If you go to Italy, around 1/3 get infected. If you go lately to US, we have so far 9,300 healthcare workers contracted COVID-19 till now. 27 died, 8% asymptomatic, and 5% required ICU. Unfortunately, more than 1/3 of these people died is over 65-years old. So really, the story is terrible, and we are not understanding anything. It is a zoonotic virus. Why infected human? Why we get infected with zoonotic virus supposed to be transferred from animal to animal? Most of the scientists raise this question: why humans get infected with COVID-19? We thought that because we have a very weak microbiome, the HCl of the stomach, our acid in the stomach, is very poor. We are intoxicated. Most of the human beings are intoxicated with heavy metals, which depress the immune system. We are eating very bad kind of food, refined, processed, low nutrient food. So really expect that your immune system is poor, especially no exercise, poor sleep, continuous stress. So don't expect that you have a perfect immune system as the Creator gave you. For example, if you look at our food, around 99% of our food containing pesticides, in addition to hormones, heavy metals, a lot of material toxic to our body. For example, you have a calcium bromide as a whitening material in apple and grapes. We have a waxing DBA, which is actually linked to cancer and autoimmune disease, aluminum and foil in water pipes, pesticides, herbicides, fungicides in all kinds of plants. We have sulfate in polyethylene glycol, and carbon and lead in smoke inhalation, even the fish containing mercury and lead. So we are actually having toxins everywhere, with a lot of radiation, mercury in dental amalgam, fluoride in toothpaste, arsenic in rice, and lead in vaccines. So don't expect that you will have a perfect immune system to identify the abnormal viral DNA. So we'll end with very weak kind of population, exposed to plenty of microorganisms without an actual army to defend. But we have a good news. If you look at the world, you'll find around 15 countries all over the world, they have a zero coronavirus. Some of these countries, actually, like North Korea, they applied the quarantine very early, but the rest of the countries are mostly living on very healthy kind of food. So nothing in life to be feared, it is only to be understood. Now is the time to understand more so we can fear less. This is a Marie Curie Nobel Prize in Chemistry. If you look at the HADZA state, for example, is the biggest state in Tanzania. They have a zero coronavirus. When the scientists look in depth to HADZA state, they found those people have the strongest microbiome all over the world. They have the richest gut microbiome. Diversity of the gut microbiome is 40% more than American, 30% more than British, so huge seasonal variation also there regarding the planting and animals. They eat 600 species of plants and animals a year. Most Westerns, they eat less than 50. So ask yourself how many species of plants and animals you are eating per year. Very unlikely to have obesity, allergy, and ischemic heart disease and cancer. So also for the COVID-19, they have a zero COVID-19 case, despite they are living in troops and they're easy to get infected. So is it real a war? Yeah, it is a war, but we have to win at the end. We'll go to our in-hospital patients. You will find that the article came from American Society of ERAS. They told us, or they informed us that up to 60% of adult inpatients are malnourished. They have longer lengths of stay. They have a 1.5 higher readmission rate. They are actually having 4 times higher mortality than ordinary patients. And hospital cost is terrible, 60% higher in hospital cost compared with well-nourished patients. And it is very common. So it's a kind of epidemic. It's not the coronavirus, but malnutrition in general is an epidemic. Another article telling that every 60 seconds, 10 hospitalized patients will go undiagnosed with malnutrition. And it is not an epidemic, it is a tragic, because we are not feeding patients well in the first weeks of hospital admission. And we know clearly that how you feed your patient in the first week of hospital admission will change quality of life months later. That's why the scientist Paul Wishmer asking, are we creating victims or survivors inside the hospital? I believe we create victims more than survivors. So what are the new concepts while you are providing nutrition in COVID-19 patients? So I reviewed the new guidelines, Australian Society of BN and EN. We published April 2020. Also the ISBN, they have a statement which is still in press, published a couple of days ago also. So we have some recommendation from the experts. We are going to we'll go through it, especially Australian guidelines. But as I told you, we don't have very strong evidence. So we are dealing with extraordinary problem. So we need to deal with it and solve it by extraordinary solution. So evidence-based medicine, our strict evidence-based medicine is not really going to help much. We have to follow personalized or individualized medicine because we have heterogeneous group of patients. We have to think outside the box. So the first challenge, when you insert the nasogastric tube before starting feeding, we have to insert nasogastric tube. Here's the recommendation to have personal protective equipment. Same like a physician inserting central line. It's very, very, very important to take precautions. So because your safety is a priority. Also, it's important to understand that the NGT will stay post-extubation because we did not expect that COVID-19 patients will actually be fed well post-extubation. They have a loss of taste, smell, which is very difficult really to have a good appetite. So we need the NGT to continue until patient will able to have more than 50% of caloric and protein target. But don't forget to change it into smaller one before extubation to be tolerated by the patient. So we need to take care, and again, your safety is a priority. So assessment of nutritional risk is the first question, how to assess nutritional risk during COVID-19 era. So Australian guidelines, they give you around 7 assessment tests, because we are not expecting that you go through full assessment risk by dietitian or nutrition care team because of the shortage of the staff and the exceeding capacity of the healthcare worker. So pre-existing malnutrition, recent weight loss more than 5%, actual body weight less than 50, BMI less than 18.5, obese patient also with BMI more than 40, requiring patient parenteral nutrition, high risk of refeeding syndrome, type 1 diabetes, cystic fibrosis, inborn error of metabolism. So we believe that it will be simplified. So modified Nutri-Score will be followed in critically ill patient. If more than 4 is a high-risk patient, need special attention, and must a scoring system, a malnutrition scoring tool, more than or equal to identifying high risk should be carried on in non-critically ill patients. So we expect that role of dietitian is not much here, because we have a shortage of dietitian and nutrition care team all over the hospital. So we need to depend on the senior nutrition nurse. Most of the hospitals, they have a nutrition care team, and they trained well their nurses to take care. We have in our hospital senior nutrition nurse, which is supposed to have a screening tool with a MAST or Nutri-Score to identify high-risk patients, as well as to patient who is identified high risk will be referred to dietitian within 24 hours, and low risk patient will actually can be seen within 3 to 7 days. You don't need to see by dietitian urgently. Our nutrition care team will be reserved to patients who are very complicated, because we don't have a luxury to provide it to every high risk patient. So training of allied healthcare worker is very, very, very important at this point to take care or to take your role during this critical bad time. Also, don't forget to go with telecommunication, so we can communicate with the dietitian over phone, the kitchen over phone, and to minimize the risk of infection to the nutrition specialist and nutrition technician. So telecommunication does work now with all aspects of healthcare work. Calculating energy targets is also an important issue, how to calculate. So don't forget that using indirect calorimetry here carry high risk of transmitting infection. It is a gold standard method, yes, but it needs mechanical ventilator disconnection. It needs prolonged time with high exposure to the patient. So no more indirect calorimetry when you are calculating the calorie target. So we will rely on simplistic equation, which is based on actual body weight. If the patient is less than BMI less than 30, we will start with 15 kilocalories per kg per day. Then we'll go to 25 kilocalories per kg per day after day 4 to day 7, and then later on you start with 30 kilocalories per kg per day. Don't forget that patient with high risk of refeeding syndrome, we need to start lower at 10 kilocalories per kg per day. And obese patient with BMI more than 30, you should go with adjusted body weight. And here you calculate simple equation, ideal plus 0.25, the actual body weight, they give you adjusted, and then you go with 25 kilocalories per kg per day. And don't forget that obese patients deserve really more attention. And the ICU, always telling that ICU is not the best place to lose weight. So the message from the experts, I like my friend Dr. Amr Matar is always telling, start low and go slow, and you build up over 1 week. You should not start high and go fast. But why? Why you do like that? What is the reason? Why not start from 25, 30 kilocal per kg per day? So the simple answer is we would like really to avoid actually overfeeding, which is overfeeding is very hazardous in critically ill patients, because patient will go to refeeding syndrome very fast, and also increased calorie will increase CO2 production, and this will really impair weaning from mechanical vent, and a lot of problem if you go to overfeeding. So we should not feed critically ill patient with full EN or BN from day one, but to be prescribed over 5 days. This has been stressed by ASPIN guidelines and old ASPIN and also Australian guidelines, which have been published a week ago. And we understand clearly that patient categorized into 3 groups. The first group called acute phase or early period, and second group called acute phase late period, and third group will be called late phase group. The early phase group will start between day 1 and 2, and acute phase late period at day 3 to 7, and the late phase start after day 7. So we expect that earlier the patient has high calorie enough from endogenous carbohydrate production, and so that's why here we need to go very low and slowly build up over 3 to 7 days in the late period when the catabolic state is less, and when patients start to be anabolic, we will actually go with full caloric requirement. Even we exceed the calorie 25, we'll go to 30 kilocalorie per kg per day, because patient in rehabilitation phase. Some of the patients will go to chronic phase, with very low immune system and severe or low continuous hypercatabolic state, and most probably this patient will not survive. This is the reason if you look at the endogenous glucose production will be very high with hypercatabolic state, especially when you have an insulin resistance, so which is enough to generate 50 to 75% of glucose requirement. So one size doesn't fit all. So this will raise more questions, more questions. For example, what about protein target? We talk about calorie target or energy target. What about protein target? ASPIN guidelines suggest to start protein little bit low and average to be 1.3 gram per kg per day over next few days. If you look at the new Australian guidelines, they suggested to start with little bit high protein. They start with 1.2 gram per kg per day, because the patient, when you will see the patient with COVID-19, mostly for 5 days to week time, get worse with hypercatabolic state and not eating well because of loss of taste and smell, because the protein will be lost, and if you continue like that, the muscle mass will be significantly depleted. So does really COVID-19 patient needs high protein like other critically ill patients? Yes, protein is an integral part of the Chinese puzzle, like lipids, carbohydrate, electrolyte, trace element. And protein is needed to build up and maintain body tissue. Also, protein is utilized for energy in increasing amount during stress. So protein is the foundation. You cannot build bricks without really having protein. And protein turnover is terrible during COVID-19 critical illness. You have to understand that the protein breakdown is actually around 350 grams per day, which is 5 times your protein census. So don't expect that when you're getting like 0.8 or 0.6 gram protein, you'll be fine and protected. Because the net result will be what's called progressive rapid loss of body mass, septic autocannibalism, and will end with anabolic resistance. And here, whatever you do, you're not able to succeed. You will lose the war. You will not have army to defend you. And you will enter to a zone which is called PICS, or persistent inflammation, immune suppression, catabolism syndrome, which is a phenotype of multi-organ dysfunction with low multi-organ dysfunction syndrome, more commonly in elderly, length of stay more than 14 days, with having low-grade organ dysfunction. Patient enter PICS will have recurrent infection, immune suppression, going from renal failure to liver failure to multi-organ failure, and by the end of the day, they will not survive. So what's the basis for protein requirement? Critical ill patient, they have a severe critical illness, especially with COVID-19. They have a loss of 1 kg lean body mass per day. In certain studies has been done in the past, showing that severe critical illness patient might lose up to 1 kg of lean body mass per day. And loss of lean body mass is associated with severe critical illness and can accelerate severe critical illness. So it's a kind of vicious circle. So to get rid of this vicious circle, you need really to supplement protein early. We know clearly also that loss of lean body mass is associated with mortality. So if you lost around 40% of body mass, believe me, your mortality will be 100% or more. So khalas, the patient is already dead. Does increased protein reduce mortality? From evidence-based, Albrada trial, it revealed that any extra 30 gram protein is associated with decreased mortality. And MetaBlast trial also, when you look at immune nutrition plus high protein versus high protein alone, they found no difference because of both arms received high protein. So the message from MetaBlast trial from Van Zanten that we need to supplement high protein for all kinds of patients, especially during hypercatabolic states. Also, the new protein health trial, which published last year, protein vent trial, sorry, published last year, revealed that early protein is better than late protein, especially in mechanical ventilated patients more than 7 days and associated with decreased 60 days mortality, 36% versus 43%. And if you go for Dan Hilland, 2009, long time ago, when he created his PEP-UP protocol, you find clearly that he started with calorie low, 15 to 17 kilocal per kg per day, and a formula which is calorie dense, 1.5 kilocal per ml, semi-elemental, high protein. And in spite of that, he started, because at that time maybe the formulas were not containing that high protein that we have now. So all patients, they added a kind of modular protein, whey protein, 14 gram, 120 ml of water TID. But we believe we need a formulas which containing high protein, so not add much water, because COVID-19 patients, they already having much extra water in their lung. So we need really to give them what's called fluid conservative strategy. So to give formula 1-to-1 is going to create harm. Giving a protein low formula going to create harm. We need to add modular protein, which need large amount of water, which really put patient into vicious circle. So not able to wean from the mechanical ventilator. Are all proteins the same? So we have peptide form, we have amino acids, we have intact protein. And also we have kind of arginine, glutamine, nucleotide. So we learned that casein protein is much different from whey protein. The protein in milk is composed of casein protein, We have casein 1, which is coming from cow milk. We have casein, which is really inflammatory. This inflammatory, we know that the kind of casein 1 protein is very inflammatory, one of the causes of like autoimmune disease and link it to cancer as well. And we have a whey protein, which is much less inflammatory and actually water soluble, easily absorbed, high in leucine, and as we can potentiate muscle synthesis. The casein protein, especially casein 1, is going to cure in the stomach. So difficult to leave the stomach early, which impair digestion, and difficult to get absorbed as well. We know that enteral glutamine also has been suggested by SBIN guideline 2018, especially in trauma and high-risk surgery and burn patients. We don't know actually in COVID-19 is going to work or not, but we believe that any doubt or benefit we need to use, because this kind of immune nutrition also is able to reduce bacterial translocation and is able also to support the cellular metabolism. Also, we know from the ASPIN and SBIN guidelines that surgical subset of patients will get benefit from higher protein up to 2.5 grams per kg. We know that we need to supplement extra 30 grams protein per liter lost in the volume loss per JVAC or per drain. And we know that arginine fish oil is actually beneficial in traumatic brain injury. And we know that also like arginine fish oil and nucleotide is going to help in high-risk surgical patients associated with loss of decreased mortality. So we need to use high protein with very strong evidence. Obese patients need high protein up to 2.5, even more grams per kg per day. So when we go to talk about the whole protein or peptide form, we would like to stress on that. Semi-elemental peptide form protein are far better than intact protein when you treat COVID-19 patients based on our experience. We know that those kind of peptide is easily to be absorbed through the gut, and because of abundance of peptide carriers across the small intestine. The other form of protein, the carriers is going to be depleted with hypercatabolic state. So please just use peptide form, semi-elemental, during severe critical illness, especially with COVID-19, until proved otherwise. So we learned from the previous slides that we need to go to semi-elemental, protein dense and calorie dense as well to reduce the whole fluid positive balance. And also immune enhancing might be really has an outcome benefit now and has been stressed by new SBIN proposed guidelines. Are all lipids are the same or not? We know that soybean oil, the lipids are composed of, we have a soybean oil containing omega-6, we have coconut oil containing medium chain triglyceride, we have an olive oil containing omega-9, we have a fish oil containing omega-3. So important really to understand that the more you go here, the more you will go to more pro-inflammatory. And the more you go here, the more to go to less pro-inflammatory. So here pro-inflammatory, here anti-inflammatory. So we need really to go with fish oil rather than to go with soybean oil. The idea of fish oil use has been stressed extensively by new SBIN guidelines to 2020, which published last week. Not published actually on press currently. There is no word from Australian guidelines about fish oil, but there is extensive talk about it from SBIN guidelines, because we thought that we are getting too much omega-6 fatty acid. Even when you use propofol, it is actually getting a large amount of omega-6 fatty acid, which is going to be towards the more pro-inflammatory mediators release, which patient having already cytokine storm and severe hyperinflammation. So we need fish oil having ABA, DHA, which is a very strong anti-inflammatory antioxidant, modulate sense of icosanoid and activity of nuclear receptors, as well as production of resolvine, which is the strongest anti-inflammatory in the world and immune mediator in the world. So really we need to go with fish oil rather than to go with omega-6 or soybean oil. What is the evidence? We know that from the cytokine storm, which is common during COVID-19 patients, that when patients have infection or stress or whatever, you'll have severe systemic inflammatory response syndrome, and the body will react with CARS, compensatory anti-respiratory anti-inflammatory response syndrome, with release of anti-inflammatory cytokines. When you get fish oil immune nutrition, you're able to reduce the SIRS and improve the CARS. And even later on in the disease, when patient has immune suppression, immune nutrition does work to reduce inflammation and to improve the immune function. Bonte-Eroda, a long time ago, 2006, he has a study revealed that in severe sepsis and ARDS, using Enteral Nutrition with EBA, GLA, is able to reduce risk mortality by 19.4% with huge mortality benefit. And even ventilator-free days is and ICU-free days are less. BO2, FiO2 ratio, so oxygenation are much better. So I am thinking that it may be wise to use immune nutrition, especially fish oil, arginine nucleotide, glutamine also may be added, especially if the patient is vitally stable, have a good hemodynamics and no multi-organ failure. Do we need to check GRV or not? This is an area of debate between the Australian and ESPN guidelines. So the Australian SEC asked it to check GRV 8 hourly for 72 hours, then no further check if GRV less than 300. Then if patient intolerant to feeding, you use combo strategy with IV metoclopramide 10 mg IVQ 6 hours plus IV erythromycin 200 mg IV BID. We need to consider post-biologic feeding if GI intolerance more than 7 days. I totally don't agree about it, and the ESPN as well don't agree about it because it carries high risk of transmitting infection to healthcare workers. Here, ESPN mentioned clearly we depend on other factors of GI intolerance rather than GRV, or gastric residual volume, like abdominal distension, vomiting, like that, but you should not really go with the frequent checking 8 hourly and exposing staff to high risk of transmission of infection. And I don't think post-biologic feeding, and also ESPN don't think that post-biologic feeding is the best time to use it now and to transfer patient to endoscopy or fluoroscopy or whatever to have the best site for post-biologic feeding. So difficult to insert post-biologic feed tube without really fluoroscopy. The question number 7, can we reduce calories, protein depth or not in critically ill COVID-19 patient? We have terrible interruption of feed. If we can reduce interruption, we will be able to reduce calorie and protein depth. Imagine 12 hours before, after elective surgery, unnecessary. ERAS guidelines telling like 6 hours for solid, 2 hours for fluid, clear fluid. 12 hours interruption before and after planned extubation. Stupid, because really, actually, you every day you are checking the patient is not fit for extubation, so postpone the feeding, resume the feeding, and will end with huge amount of calorie and protein depth. 6 hours before CT scan, ultrasound, patient is going to do CT brain, and then you stop feeding. What is the reason behind that? Indefinite time on non-invasive ventilation. I don't know why you are keeping patient without feeding. If you cannot feed enterally, you feed parenterally. If the patient during off time non-invasive ventilation, you feed them. You give them oral nutritional supplement, but don't leave them without feeding on BiPAP for decades. Indefinite time on prone position. We'll learn together that prone position is not a contraindication for feeding. Okay, and also the surgeons are very enthusiastic about bowel resection and said like patients stay 2 weeks to 1 month of feeding post bowel resection. And we know that even going with trophic feeding will be able to strengthen the anastomosis. So it will be beneficial rather than harmful. Feeding in prone position also has been discussed with the guidelines, and they clearly asked to stop feeding before turning the patient and aspirate before turning the patient. And then after turning the patient, check the NGT position. If like position is fine, then resume feeding and again check for the once the patient turned safely. And here you can return the feeding which you already aspirated as well, because really we don't need calorie and protein depth. So with any turning, you need to stop, aspirate, and then check the position of the tube, and then again return the GRV. We know that ICU patients usually get for 50% of EN goal, no modular protein added. So protein delivery in the best center in the world is about 0.6 gram per kg per day. And they found in the studies that 14 days caloric depth around 20,000 kilocal, and 14 days protein depth is 1.5 kg, which is terrible. If you reach to that point after 2 weeks, believe me, your patient will not survive. Another question, number 8, should we give high-risk COVID-19 patient oral nutritional supplement, ONS, or not? We should. I believe any COVID-19 patient, whatever is high risk or low risk, it should receive oral nutritional supplement. We know from ERAS that each $1 spent on ONS is actually associated with $56 reduction in the hospital cost. So believe me that patient lose taste, smell, appetite, so is not able to eat and drink well. So here you have to supplement with ONS. You have to supplement with ONS, otherwise the patient will go to anabolic resistance. Believe me, a lot of calorie and protein there. Also an important question, debatable. Should COVID-19 patient receive medicinal supplement or not? Like zinc, or vitamin C, vitamin D, or like that. Actually, has not been, no comment from Australian guidelines, but we have nearly a full page from ESBIN guidelines. And we know that Marik, Professor Marik from US, one of the most expert scientists in the field of supplement, and he used his supplement during the septic shock patient and able to make most of the patient with severe septic shock, multi-organ failure to survive. So Professor Paul Marik has a protocol as well in COVID-19 patient. He used vitamin C, vitamin D, zinc, and quercetin when the patient exposed to COVID-19, before having the real infection. They go with vitamin C around 2 grams per day, vitamin D around 1,000 to 4,000 per day, zinc around 50 milligram per day, quercetin 500 milligram per day. And later on, if the patient got infection with COVID-19, actually they start IV vitamin C 12 grams per day, 3 grams, 6 hourly for 7 days, and vitamin D 4,000 daily for 7 days. And he used also zinc at dose of very high dose, 100 milligram daily for 7 days. He believed, and we believe, that vitamin C can boost all immune cells like neutrophils, natural killer cells, TNF IFN, interferon released by cytotoxic cells, actually can prevent virus from entering the cell. So a lot of benefit from vitamin C. Without vitamin C, you will not have a good immune system. So the vitamin C is a fuel for immune system. Vitamin D, we know that when the virus enters the host, first thing to do to try to block the vitamin D receptor. If the vitamin D is good, you will have a strong immune modulation. So our immune system will able to identify the virus by T memory cell and able to stop viral from entering the cell. So without vitamin D, also you will not have a sound immune system. Zinc is important inside the cell because when you have viral infection or abnormal viral protein, the zinc will enter quickly into the cell and will stop the RNA transcriptase. So we're able to stop the viral replication. Even the chloroquine and quercetin will work through mobilizing the zinc fast into the cell. I'll tell you also a secret that the patient with COVID-19 will lose the taste and the smell because of severe consumption of zinc and severe zinc deficiency. When you go to look at the actual signs, or the first sign of zinc deficiency is poor taste and poor smell. So zinc is very crucial for the immune system. Zinc is a cofactor for 1,000 of enzyme. You will not have a normal mitochondrial function without having adequate amount of zinc. And this kind of minerals are called trace minerals. So it's not really present in our food in a good amount. So we need to have a supplement during the era of COVID-19. Of course, we don't have a very strong evidence for that because we are really facing COVID-19 recently. So maybe in the future, we'll have more evidence. Interestingly, if you go to goats, so goats are very smart animals. So a goat, they're able to sensitize vitamin C. They sensitize daily around 13,000 milligram vitamin C per day. And important to understand that the goat during stress or infection, they're able to sensitize 10 times higher vitamin C than ordinary days. It means that vitamin C really is a very important thing to have during infection or sepsis in general. When to start parenteral nutrition also is an important question. We talked before about early acute phase and late acute phase. Early acute phase start in the first 2 days and late acute phase start after that to continue to 5 to 7 days, and then to go to anabolic phase or late chronic phase. So we think that if you start parenteral nutrition early here, is going to have a high risk of overfeeding. But if you go and not start supplementary parenteral nutrition here, you'll have a high risk of underfeeding without parenteral nutrition. So if you think about supplementary parenteral, think about after day 4, at day 5 exactly, if the patient is not able to tolerate more than 50% of the caloric target. So if the patient, you have to deal with COVID-19 patient, if the GI is intact, yes, you start early enteral nutrition. Here we go early at first 24 hours, not in the previous guidelines in SBNF within 48 hours. And important to understand that if the patient is not able to tolerate the GI enteral feed, you have to assess if the low-risk patient or high-risk patient. If high-risk patient will go with early parenteral nutrition after day 2. If low-risk patient, you'll go with a late parenteral nutrition. After 96 hours from early enteral nutrition, you're going to ask yourself if the patient is not achieving more than 50% of caloric needs. So at this time, you need to have supplementary parenteral nutrition. And high protein is a must, and early high protein is a must with either enteral or parenteral. So take-home messages: optimal nutrition therapy only achieved when you have protein and energy target met. And when you achieve enough protein and energy target, you will able to have 50% reduction in mortality, while reaching only energy target is not associated with reduction in mortality according to the Weiss trial. And we learned also that fish oil not only target calories and protein is a power couple, but also fish oil and protein must now be seen as a power couple in the new nutrition paradigm. So we would like really, when you start to feed the critical ill COVID-19 patient, to choose the best formula, which is, we believe that the best formula, and most of the scientists believe during COVID-19 era, to have calorie dense, 1.25 to 1.5 kilocal per ml, high protein, so you don't need to add modular protein from outside, providing at least 1.2 grams per kg per day. And important also to have omega-3 fatty acid to be away from inflammation, which is already very high during the COVID-19 infection. Finally, I would like to thank you very much for your attending the presentation, this long presentation. And I would like to thank Nestle again for sponsoring such a good event. And I hope the lecture will be of value for all of you. And I will leave now the mic for question and answer. Thank you very much.